Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Good evening and welcome to Dialogue with a Doctor. This is a show where we interview physicians, local physicians, and learn about themselves, their practices, so that you can learn more about medicine. And we're here this evening with Dr. Kevin Lamb. He is a practicing board-certified foot and ankle specialist, a surgical foot and ankle specialist, and further certified in reconstructive surgery. That is not common, and we're going to hear more about that. But first, let's ask Dr. Lamb who he is, where he came from, and how he got here.
Well, thank you, Greg. Well, I was originally from China, raised in New York and Philadelphia. I went to school in Philadelphia, trained in Philadelphia and Miami, and then here I am in Naples. Been here for 10 plus years.
So, in training, how long did you spend in Philadelphia? How long does it take to learn what you learn?
Well, Philadelphia went through 4 years of podiatric medical school, and then I did my first year residency in Philadelphia before I went to Miami to finish up my training.
Okay. And so in Miami, is that where you learned the reconstructive surgery?
Yes, in Miami, I learned the trauma surgery and the reconstructive surgery in Miami.
So then you just came over here to the other side.
Yes, they were trying to recruit me to keep me over there on the East Coast, but I needed something quieter, so.
Well, I think that was a good choice because really you're the first and just about only person here that does what you do. Can you tell us where your offices are located?
Yes, I have one downtown, which is the one I work out of, on 661 Goodlet Road. I have a North Naples one on Immokalee Road. One of my associate doctor works up there, and then one in East Naples along East Trail across from the Lely Horses on 41.
So 3 locations, and you have 3 surgeons total?
3 surgeons and a fellow surgeon, yes.
And who are they?
One that handles North Naples, Dr. Rami Fahim. One in East Naples is Dr. Drew Chapman.
Good. Well, I'd like to meet them, and I think I will soon.
Yes,
I'd like
you
to
will.
interview one of those. So we're going to talk about multiple things tonight. I'm going to let you start where you would like to.
Okay. Well, this last couple of years have been very popular. The what we call has been nicknamed the lamb bunionectomy because it's an old-fashioned bunionectomy that was done in Italy for a long time, and it fell out of favor because of screw fixation. When screw fixation came in, then the surgeons started to open up the foot more and want to make it more. They think it's more accurate when they open up, put a screw in. So because of that, it fell out of favor. They thought it was very unstable. But the modification that I made to this bunionectomy, I still do the same cut, but I make it through a 6mm incision. My equipment is very small to make precision cuts, and I do not disrupt any ligaments, important ligaments, blood vessels, or nerves. There's no chance of cutting them. There's no chance of damage when I do this bunionectomy. And I rely on the soft tissue and nature to hold everything together, along with just one pin that is removed in 4 weeks. So ends up being the scarless lamb modified bunionectomy, as it's called right now.
Can you remind our viewers what a bunion is and what part of the foot that you're working on when you do that?
Yes, the bunion is it's off the big toe joint. A lot of times you see it in movies. They say, rub my bunions. Bunion pretty much is a big protrusion off the side of the big toe. So this is the big toe. It will say a big protrusion out this way. You have a nice big bump on the side. That's what a bunion is. And a lot of times we get red, hot, and inflamed. Sometimes you will see ladies out in the, since we wear sandals a lot, I will see them where you see the second toe overlapping the big toe. Well, that's a severe bunion where the bunion has dislocated, now it's riding underneath the second toe. And that's when you'll have an overlapping second toe with a severe dislocated bunion. You never want to reach to that stage before you come and see me.
Yes, it's harder to fix when it gets that way, isn't it?
Definitely, our options are more limited when other joints start to dislocate.
So bunions are common. I think they are, and it's probably a common procedure. So what's the recovery like with the lamb bunionectomy?
The recovery for me is I've actually had doctors and nurses in this town that have actually had this done. I do them on Thursday afternoons in the comfort and of our surgical suite. I do them on Thursday afternoon, and they're back to work by Monday morning. I tell them, let me do this procedure Thursday, and take the weekend off, take it easy. By Monday, come in early in the morning, I'll change your dressing and get you back to work in the surgical boot. And they do. Surgeons and nurses have done that.
That's pretty amazing compared to the way it used to be.
Yes, the way it used to be, and it's still done the other way with the screw fixation and numerous other procedures. And you know, since I've modified the procedure and I've done tons of these, I would say average of 10 a week now.
Wow.
And each bunion, you know, my last record was about 4 minutes to get a bunion done, and you know, patients recover a lot faster.
Yeah.
Pain is a lot less, to almost none.
Wow, that's come a long way.
It has, and I think one of the most limiting factors of why people don't get bunionectomy is because A, they're afraid of the pain that they'll have, and B, they don't want to be off their feet for 6 to 8 weeks. Well, we eliminate both issues. They're not going to have any pain for at least 24 hours because of the anesthetic that we give them locally. But on top of that, we also give them a pain medicine that I always tell the patients, don't play catch up with your pain. Take it. I know you're going to be numb for 24 hours. Just take this pain medicine, at least for the first 3 days for me. And a lot of times after that first 3 days, patients say, hey, no, I don't even need it. Don't even need Tylenol. And they're back to work. And that's the most important thing, getting our patients back to work early.
Stay ahead of the pain, get back to work.
Yes, indeed. Imagine taking 6 weeks off of work. It's pretty hard.
Very good. Well, tell us more about what other things you do as a specialty surgeon that you are.
Well, I deal with more of the complicated ankle fractures out there. You know, sometimes people fracture their ankle, you get one bone fractured, but a lot of times when we get called into emergency room, we get called in for the more complicated one. The ankle is probably in like 5 or 6 pieces by the time they call us, or an older patient where the bone is very osteoporotic and they fall and the ankle falls into numerous pieces that you can't even count. That's when they call us in. Let's say a child with flat feet that hurts. They tried orthotic therapy with other physicians and they've gone beyond that. So we will fix childhood flat feet, we'll fix adult flat feet. Club feet is not as common anymore, but you know, when it was more common, that's what our specialty used to do. But we do see some residual clubfoot deformity now, and we do get patients coming from other countries coming in where they do not have as good of a prenatal care as we do here, or early orthopedic care when the child is born with casting. So they come in with adult flat clubfoot or progressive clubfoot as they become adults. So we end up having to fix those kind of deformities.
Well, complex ankle fractures, I know in my practice, many orthopedists don't do ankles. They don't do that kind of fracture, and usually I recall seeing them in training, but it's very few and far between, it seems to me, surgeons that are trained to do what you do.
Correct. I mean, like anything in life, the more you do them, the better you're at it. I'm in the ankle joint every week. I'm looking at it from either a scope, I'm looking at it from a reconstructive standpoint, I'm looking at it from a limb salvage standpoint. So I see it so much, and so reconstructing an ankle is not that hard to do when you're looking at it every week.
Well, it sure looks impressive on an x-ray when I see it. I wouldn't know what to do.
Oh, definitely.
That's for sure. So you were talking about childhood flat feet.
Yes.
Tell us about that.
Well, a lot of time I get patients that come in, you know, I have two extremes. I have one extreme where parents are ultra worried when they're not to be worried, and then I've on the opposite end, parents are told the opposite. They really should be worried and they're not. And I think there's a difference in the pediatric community also in regard to this, to the opinion of what to do with flat feet. So I would say, I mean, according to the American College of Front Ankle Surgeons as well as the American Academy of Pediatric Orthopedics, they work together to put together this flow chart of what to do with these kids. And I guess the word hasn't gotten out there yet to everybody. So between the Pediatric Orthopedics and the American College of Front Ankle Surgeons, which I'm a fellow of, They're saying pediatric flat foot, if they're not symptomatic, make sure they wear good shoe wear, orthotic therapy, and just watch them. Beyond that, if they fail conservative therapy such as orthotics and proper shoes, and the kid still complains about pain, then it's time for us to step in. And luckily, because I do so many of these procedures also, you know, we do them fairly quickly, easily, and without any complication to our pediatric patients.
So sometimes they come too late. So it sounds to me like they all should come so you can figure out, tell them what the protocol is. So is that what you meant?
Yes. They actually, if you're concerned about your child, come on in. Let us take a look at it. Let us take a look at it. We'll be able to tell you, hey, you should worry, you should not worry. We should just watch it, type of deal. Now we've educated some of the pediatricians in town, and they do that. Some don't, but can't change everybody.
Well, we're going to take a short break, and we'll be back in just a few minutes.
Thinking of buying a home located in a golf course community in the Naples, Marco, Bonita, or Estero, Florida? Here is what Mark Lai, former PGA winner, says about Realtor Michael York of the York Real Estate Group of Downing Fry Realty.
Hi, I'm Mark Lai. If you have any real estate needs in Naples, Florida, the one company to contact is the York Real Estate Group. Also, if you want a golf course property to invest in, Michael York of the York Real Estate Group is the guy to contact. Michael knows every golf course in Naples. I will tell you this, he's been in the golf business for a long time. He's played all the great golf courses down here, and he is an outstanding realtor. I've known him for quite some time, and he's he's got a lot of integrity, and he very much knows his stuff on all the different clubs here in Naples. So the York Real Estate Group is a great place to start. So if you have any time or anybody that wants to visit down here in Naples and look at the options out there, please contact the York Real Estate Group.
Welcome back to Dialogue with the Doctor. We're glad to have Kevin Lamb back here, Dr. Kevin Lamb, who's a practicing foot and ankle surgical specialist, and we're learning a lot about new things today. We just got finished talking about flat feet, and you said something about club feet too. Can you tell us a little bit about that?
Well, club feet, yes. Club feet used to be more common in the United States before all this great prenatal care that our patients are getting nowadays. So we don't see it as much in the U.S. population. But because we're in South Florida, we do get the Latin American population, we get other people from other countries. We're still quite prevalent, and pretty much club feet typically happens on the left foot, and it's a contracture. It's a contracture of the foot where the foot is bent almost inward. So the person is walking on the side of their foot rather than on the bottom of their foot. And again, we don't see that as much in the United States anymore. But right now, what we do see is that people coming from other countries, and we're ended up doing reconstructive surgery on adults with recurrent clubfoot or undercorrected clubfoot from other countries. I think pediatric orthopedics, as well as our pediatric subspecialists, have done a really good job in the hospital setting in catching these kids early nowadays. And if we catch them early, we can just cast them out of this clubfoot without any surgery.
So you were talking about with good prenatal care. Can you tell us what you meant by that we see less of it because of that? Well,
prenatal care is just as care for the mother during her pregnancy, such as multivitamins and et cetera, and close monitoring of the amniotic fluid levels, et cetera, through ultrasound. That's what I meant by that, keeping the mother healthy.
I guess I didn't realize what the cause of club feet is. Do we know what the causes are?
No, there's a few theories out there, but there's no direct link. But we do notice that in this country is not as prevalent anymore.
I see. Very good. Well, tell us more about your practice.
Well, our practice is very unique. My practice, we deal with podiatric foot care, but we also deal with reconstructive surgery, which makes us a lot different from a lot of my contemporaries in this area. There's only about 900-something podiatrists in this whole country, actually the whole world, that actually has the double certification. And that double certification is a requirement that we look for when we recruit our doctors. So we're going from a very small pool when I recruit my doctors. And then our standards are definitely very high as far as taking care of our patients.
So all of your physicians are double certified in the reconstruction?
We're seeking double certified or board qualified, so they can sit for the certification board. So at least they have to have the basic training to go towards that. Board certification in our profession is a little different from the typical medical profession. In our profession, we have to do a didactic part of it, which is taking a test of what you know book-wise. If you pass the book knowledge, then you have 7 years to do the surgeries to prove that you have good results on a consistent basis, and those are the reconstructive cases that we have to do to prove our cases. You go in front of a board of your peers that are that are also double board certified, and they go through your cases, pick them apart, and give you a hard time, and decide if you're going to be part of them or not.
Yeah, I remember being given a hard time.
Yes.
So, in your practice, what type of technology is used in reconstruction or foot surgery?
Well, the technology that we use almost looks like a toolbox nowadays. I mean, a lot of major orthopedic companies now are focusing on the foot and ankle. They're realizing that the foot and ankle is a big market. People are being active. There's a lot of degenerative joint disease that starts off at the foot level, that goes up to the ankle and the knees and the hip. You don't fix the foundation, the other joints are going to go. So a lot of the major orthopedic companies like Zimmer or Stryker, they're coming out with a whole array of different plates and screws and all sorts of devices so that we can help the patient to fix their feet, to put them into a proper position so they can function, so they can be active.
I should say, foot and ankle issues, have they been undertreated in the past because of lack of technology?
I wouldn't say undertreated. I would say we didn't have as much options and technology back then. So they were being treated, just treated differently. What's different nowadays is with advent, especially with my bunionectomy and advent of better scoping technology nowadays by Arthrex down the road, we're able to do a lot of sport medicine-like work on the foot and ankle now than we did before. A lot of time back in the old days, I used to hear, hey, if your foot doesn't hurt, it looks ugly, don't fix it. Well, I think the reason why behind that, such as people saying that for bunions, I hear that a lot. My doctor said if it doesn't hurt, don't fix it. And then the ladies are coming in with their second toe overlapping the big toe now. Well, it still doesn't hurt, doctor, but my doctor said don't touch it. Well, do you have back pain or knee pain? Yes. Well, your foot might not hurt, but the rest of you is hurting from you walking differently. Mm-hmm. So so the old mentality of if it doesn't hurt, don't fix it, is a little bit different nowadays because of the technology and the ability of us to correct deformity early on to prevent these kind of late deformities.
So where do you start and stop in your practice? I mean, do you go to above the ankle, or how? Tell me about that.
For us, for my practice, we start at the toes, go soft tissue, we do knee injections, sometimes we do hip injections, we have to. We could do them in the safety of the office using ultrasound, or also we have intraoperative x-ray that we could use in the office setting safely. Mm-hmm. But surgically, we stop at the distal leg, at the right above the ankle.
We had been talking about earlier before we even started, joint replacement surgery, which
Yes.
I didn't really realize was being done very often in the ankle. Can you tell us about that?
Yes, actually ankle replacement has been around for a while, I would say about 20 years, but it hasn't become mainstream. I would say it became mainstream probably about the last 5 years, Greg, and the reason why is because the results are becoming more reproducible. The technology has improved significantly. Now, in Europe, they've been doing it for even close to 20 years, but the FDA hasn't given the big stamp of approval until the last few years, just because the results are more reproducible nowadays. And in my profession, the reconstructive podiatry profession, we've done more ankle replacements in the United States than any other profession. And the ability to have a customized ankle replacement now is a reality with CT scan. So pretty much get a CT scan of a patient's ankle, and they could map out what your ankle looks like, and they'll make an implant for your ankle specifically.
Really?
Yes, they can.
So that has to be done ahead. How far ahead of time is that done?
Probably a couple weeks ahead of time. We just order a CT scan, send it to the company, they'll analyze on the computer, they'll mill out the implant, send it back to us.
That's pretty impressive.
Yes, that makes it very reproducible.
I remember you bringing an implant in last year. What is it made of? How is it put in?
Well, there's many different implants now in the market since the time I brought that one in. Basically, it's made out of metal, 2 metal components, and then there's a plastic component in the middle. So you can't have metal rub against metal, so you have 2 pieces of plastic sliding against each other, and that's what the ankle implant is. Now, the ankle implant is a little bit different from a total knee or a total hip, because total knee and the hip, you just go in one plane. You just go in one plane for the knees and hip, really. For the ankle, it's something called a triplane joint. So that's why it took them a long time to get to where we are right now. The ankle bone is not what we call a hinge joint. It actually goes up and down like this in three different planes. So, but it's a lifesaver for a lot of patients with ankle arthritis that do not want a fusion nowadays. And I have a bunch of patients that have had both ankles redone, and they're doing wonderful.
Now that you mention that, it makes total sense, but that's a much more complicated joint replacement because it has to go in multiple directions.
That is correct, and it's a smaller joint too versus your knees or your hip, and it has those different directions.
What is the recovery like for ankle joint replacements?
Well, ankle joint replacement is a little bit more complicated than knees and hips now, because knees and hips, a lot of times the orthopedics want them to move right away, which is very understandable. For the ankle replacement, we're at the stage of doing the surgery, having the patient stay off it for about 6 to 8 weeks before we let them walk on it, just because the bone needs to grow around the implant stem itself.
Mm-hmm. How often they have to be off of it for how long?
About 6 to 8 weeks they need to be off that foot.
Mm-hmm. And then partial weight bearing, or
after that they go ahead in the boot for about another month to 6 weeks, depending on how their swelling goes and how their recovery goes. But typically patients do well with 6 to 8 weeks off their feet, and then another month or so in a boot, and then they're back in their sneakers and active again.
How often does it happen that, and why do people have joint replacements?
Well,
in the ankle, I should say.
Well, in the ankle, what we see in the ankle is a lot of times people get recurrent ankle sprain, or they had an old ankle sprain a long time ago, and their ankle is unstable. They never got it checked, or they never went to see a doctor. By the time they see somebody, it's because, oh, doc, my ankle hurts all the time. Well, you take an x-ray and the joint is denuded. And the best way I explain it to patients is like brakes. If your rotors are off, the brakes are going to wear uneven. So that's what's happening with these ankle joints. You're putting more pressure on one side of the ankle than the other, and you start wearing away that cartilage till it's bone on bone. Mm-hmm. And that happens with all the other joints that get replaced, and that's the main reason why we replace joints.
Is it sometimes trauma will cause a joint to be replaced?
Well, the trauma itself, no, but the long-term effect of that trauma, if that trauma, let's say you break an ankle and it didn't get set properly, and you're off by even a millimeter. I mean, that millimeter being off with all your body weight on it, 1 time your body weight when you're walking, 2 to 4 times your body weight when you're running, you can imagine that small joint getting worn out pretty quickly. Mm-hmm. So, I mean, in a study, they show even 1 millimeter off. That's why it's very important for us when we get in there for the ankle fracture. And when I train the fellow surgeons nowadays, this must be perfect. You can't be near perfect. You have to be perfect when you place these ankles back, as perfect as you can.
Mm-hmm. Yeah, that's 1 millimeter. That's pretty difficult.
Yes, that is. It's going to be. It's either we put it back perfectly, or unfortunately, the patient's going to get post-traumatic arthritis very quickly.
Well, we're going to take another short break, and then we'll come back with more education about foot and ankle surgery.
Thinking of buying or selling a home in Naples, Marco, Bonita, or Estero, Florida? Think of the most experienced York Real Estate Group associated with the #1 brokerage in Naples, Downing Fry Realty, which produced $1.9 billion in sales in 2014, controlling 43% of all transactions in Naples. Jim, Michael, and Morgan York make up the York Real Estate Group of Downing Fry Realty. With over $250 million in sales transactions, they can offer you the expertise and trust you want and need in a realtor. Call them today at 239-273-6727 or visit their website, www.naplesyorkrealestate.com.
Welcome back to Dialogue with the Doctor. I'm Dr. Gregory Leach, and we're here with Kevin Lamb. And this is, we're going to be talking about some stem cells. Tell us about stem cell therapy briefly.
Well, stem cell therapy, stem cells, what they are, they're called pluripotent cells. Pluripotent means they could be potential being many different kinds of cells. Now, when we're born, we're one type of cell, and they differentiate into everything else that we are. So that's the premises behind stem cells. But basically what stem cells are being used for in my profession and in sports medicine is for joint rejuvenation, tendon rejuvenation, ligament rejuvenation. So, for example, for myself, I used it on myself because this past year actually, I was competing in a national karate tournament and my knees were bothering me. And I was 3 weeks away from defending a title. So I said, you know what, I'm using it for other people. Let me use it for myself because I only have 3 weeks to prepare, my knee hurts. So I injected myself with a stem cell. 3-4 days later, the pain went away and I was able to compete. Basically what that stem cell is, instead of using corticosteroid, which we normally do, that's a standard protocol, we put steroid. The patient comes in with painful knees or painful ankle, arthritis is a diagnosis. If it is osteoarthritis, we'll go ahead and give a steroid shot, usually.
So the stem cells, we don't have much time, but what do they do briefly?
Well, briefly what that stem cell does, instead of the corticosteroid, which takes away inflammation via the corticosteroid, the stem cell takes away inflammation because it's made of hyaluronic acid, number one. And number two, the stem cell actually can differentiate into cartilage cells, joint fluid, that can build joint fluid for you. And studies have shown 6 months to a year out in patients with bone-on-bone knee arthritis, they've actually proven that they have some cartilage growth.
Wow. So those cells can turn into other cells. That's pretty amazing. So we really enjoyed having Dr. Kevin Lamb here with us. We learned a lot. I learned a lot, and I think everybody else did. And we really want to have you back sometime again.
Great, thank you.
Appreciate it.